this is research from my dissertation, and it's a little bit different from the work that we've seen so far. So far we've done what you can think of as sort of whole network or sociocentric analysis. This is egocentric network analysis. And there are a few ways to think about this. It's sort of an in-between for traditional statistical research using survey methods and hardcore network analysis like ERGMs and SAOMs. So the reason why you might want to do that are, well, both because there's a lower complexity level, less of a threshold for entry in the kinds of analyses that you do in egocentric networks, which are really akin to survey research quantitative methods. But also sometimes it's appropriate depending upon the population that you're looking at. So if you don't have a well-defined community of people who are interacting with each other, but you still think that relationships and networks might be important, then this might be the type of method that you want to use. So for example, patients who all have the same type of illness going through treatment at the same clinic. Now, none of them know each other. There's no whole network you can derive from that. But if you're interested in how their relationships shape their treatment experience, maybe use egocentric methods. So that's what this work is like, and I'll talk a little more about that. This is actually a preview of tomorrow. My dissertation chair, Bria Perry, is coming in and doing a presentation on egocentric methods. So you'll see a little more of this going forward. This is a painting I made to represent the onset of illness. No one ever believes me when I say that. It's not true. Yeah, it's also dated. So one insight from social science of health is that regardless of the specific conditions of illness, the particular disease, it presents in the same set of social patterns. You have to seek treatment, you have to change your responsibilities, you have new obligations, like seeing a doctor, relationships with your friends and family change, and so on. And a lot of times, depending upon the illness, those new responsibilities and burdens can exceed individual capacity for coping. I may not be able to deal with everything that comes about with some new diagnosis or even things like having the flu. So I turn to other people for help. My research is about that help-seeking process. So who do people choose for help? Who do they go to for support, and when? And why? Do I choose people who happen to be available? Do I choose people who provide specific services that I need? Is it something that's given to me by a clinic or something like that? So that process of choosing help is something that I'm interested in. And also the consequences of that. How does it affect my health, treatment experiences, medical decision making if I go to this person as opposed to that person for support? So that's the kind of work that I do. This specific project in my dissertation is based on Alzheimer's disease. And I think this is a really good case for looking at that help-seeking process for a few reasons. So first of all, just with the epidemiological shift to chronic illness, more and more people have Alzheimer's. We're living longer. It's becoming one of the dominant health problems that we have to consider at end of life in the US and in other countries. Second, because of the nature of this illness, it's inherently debilitating. Memory loss, confusion, losing the ability to take care of yourself. As a part of all of that, people just have to start relying more and more on other people. So this help-seeking process will take place in one form or another as the illness progresses. And finally, there is no pharmacological or biological cure for Alzheimer's disease. There's no medication you can take or treatment you can go through that will stop the progression of the illness. There are FDA-approved medications to treat symptoms, help with memory loss, help with confusion, but ultimately there's nothing that we can do for people who get Alzheimer's, and their condition will get worse and worse. So in that context, there's a lot of interest in finding quote-unquote social cures or social intervention factors to help people deal with the burden of this illness in the absence of those medical approaches. So I think it's an important case. And we know some things already about social support and Alzheimer's, specifically research on caregivers. Caregivers play really critical roles for older adults dealing with cognitive impairment. In the first case, they act as sort of confidants and advocates. They're emotionally close or intimate partners or an adult son or daughter who help you deal with the sort of emotional impacts of the illness, having someone to rely on, someone to talk to just help process everything that's going on. So that's one important thing that these people do. But second, and increasingly, there's been more and more research on what you could call a care manager role for caregivers. So it's not just the case that there's someone to talk to and someone to rely on. They also have to do things like schedule appointments, manage medications, take care of certain end-of-life arrangements oftentimes. There are a lot of things that people are expected to do that they may not have any type of training for whatsoever. It can be the case that some loved one is diagnosed with Alzheimer's, and whether you like it or not, you're going to have to start taking on these additional roles. Providers actually talk about being discharged to family in this context when you have these types of illnesses. So you can think of these as sort of an emotional closeness or intimacy role, and then a knowledge, experience, and training role. And those are the two sort of lenses that I'll look at. We know that caregiving is rewarding. It can become a core part of people's identities, but it's often not a choice, and it's extremely challenging. There's a lot of research on caregiver burden and caregiver burnout, just showing that the consequences of Alzheimer's extend to these individuals often. And oftentimes, medical professionals aren't only taking care of the patients, they're trying to look after the families as well. So it's a complicated situation. Within this research, though, there are some limitations for how we think about caregiving. So specifically, we really tend to focus on a very narrow range of people who are providing support for older adults. Usually because of gender roles in our society, it's daughters who look after older adults, or also spouses. And a lot of times the organization of Alzheimer's clinics is to incorporate that one person into the treatment process. That was the case at the Alzheimer's clinic where I did this research. The problem is, we know that just from network research in general, that people rely on all types of relationships for help and support throughout the course of their life. And there's no sort of prima facie reason why older adults with Alzheimer's would suddenly stop having all those other types of relationships. They probably have more robust social lives than looking at just the caregivers would suggest. Second of all, there's research on social interaction and cognitive impairment. It's not just having a caregiver that helps people do better over time. People who are involved with community, have friends, see their neighbors, all those types of broad social interactions help alleviate cognitive impairment. But that research often uses social interaction scales, very broad measures, and doesn't drill down to relationship characteristics or specific individuals like we would want to do in network research. Second of all, effectiveness is not really well understood. If we think about these intimate and knowledge-based roles for caregiving, there isn't a lot of research on when that actually helps participants or patients and how. So in the context of Alzheimer's, it's not going to cure the illness. It's probably only going to do so much to prevent its progression. But we can look at things like secondary health outcomes, like quality of life, to see how relationships are helping people with these problems. My work on this and my dissertation has much more sort of theoretical focus. Being a sociologist, I talk a lot about culture. For this interdisciplinary audience, I don't think that's very appropriate, but I hope you'll indulge me in just one theory slide with two radically contradictory ideas from network theory. So first of all, we know that networks are incidental. We often just talk to the people who happen to be available. Like you can think about your friends in college, and it was probably your roommates, maybe, right? Because you just got thrown in with them. So we call that propinquity. I also like to think of my grandmother, in this case and in general. She had a neighbor, a 20-something yoga instructor named Jenny. And my grandmother would see her in the hallway, and they would talk every day, and they'd talk about their problems and what was going on in their lives. And then eventually, at some point, my 95-year-old grandmother would say things like, maybe I should do a juice cleanse. You know, what if I go vegan? It's like, that seems like a terrible idea for a 95-year-old. So it makes me wonder, why should we care what Jenny says about this? Like, who is this person? And it's just because she was there. It's just because she was the one who was available to talk about health and talk about how to deal with problems, and that's what my grandmother took to heart. And that's the case a lot of times in our relationships. Mario Small has a lot of great research on this, where if you think about the last time you talked to someone about something important, just that broad, they've done research to show that about 50% of the time, that's not someone you're close to. You bumped into so-and-so at the grocery store and you talked about how your kid got suspended from school. Or you just happened to vent to a friend about problems at work. It's not often these close, intimate relationships. It's just whoever happens to be there. So the implication for Alzheimer's research is that we can't really assume that these spouses, daughters, these really core, intimate partners are the ones who are going to be providing all of are the most important types of support for older adults. And we might be overlooking those broader sets of relationships that could matter for people. And second, and in contrast, networks are also strategic. So Wellman and Wortley talk about how we stock and shop network boutiques. We cultivate relationships that are useful for us. So you might have your friend who knows about cars, or you might have your colleague at grad school who knows a lot about submitting grants, and you can talk to them about that issue, right? We sort of structure our networks in such a way that there are useful things in them for us. Now, the implication here for research on health is that maybe the types of relationships that make up our networks and the types of relationships that matter most are those that match the needs of our illness. So for example, as impairment progresses in Alzheimer's, maybe there becomes a more important role for knowledge to play, whereas before, when you're doing relatively well off cognitively, that might not be that important. You can sort of look after yourself. So we can think about context and matching networks with the needs of the situation. So with that in mind, I asked some research questions in this work. Whom do older adults facing Alzheimer's disease rely on for support? Who actually makes up their supportive networks? How does network structure and support provision change with the progression of impairment? Are there contextual differences as people get worse? Do their networks look different? And then when and why do networks have a beneficial effect on secondary health outcomes, things like quality of life? So not just what does the network look like, but how does it affect people? Because those are two different things. I did research at the Indiana Alzheimer's Disease Center in Indianapolis. This is part of a network of 30 national research facilities studying Alzheimer's disease. It's housed in the IU School of Medicine. So it was usually the case, starting in the summer of 2015 and over the last few years, I would drive up to this clinic a few times a week, sit down and ask their research participants about their social relationships. They have an existing structure at IADC where they have a participant who comes in for a visit once a year. These are long visits, about 4 hours long, including things like being interviewed by a coordinator about what's going on in their life, any important changes, going through a long series of cognitive tests. There are all sorts of psychiatric evaluations for your cognitive functioning, which you could do for fun at home if you want. Those take about an hour and a half or 2 hours, depending on the participant. And then they also have an interview with a physician who updates their diagnosis and maybe prescribes medication. So all of this already existed. And then they might do MRIs and blood draws, other biomarker tests as well. And what we said, me and Bria Perry at IU, we said, what if we come in and sneak somewhere into that process and interview your participants for 15 minutes about their relationships? And they said yes, which is great. We get access to all of this great clinical data about Alzheimer's patients across the spectrum of the illness, and then we try to provide them with more social context for who's coming to the clinic, what those relationships looks like, and having a way to measure those that they're not familiar with as healthcare providers. So I would sit down in a room like this, and somewhere in the course of the visit, I would ask them about their relationships, which is great. So what did they look like? IADC participants who we talked to, out of the total, there are 233 of them, relatively older, of course, right? 71 years old, 60% women, 90% white, average education of 16 years. So relatively more women, definitely pretty white and well-educated. And that's just a limitation of the sample, it being a voluntary 4-hour-long treatment process. The types of people who have the time and inclination to do that are different from the US population. So it's something to keep in mind. But one of the nice things about this sample is that it includes people who not only have Alzheimer's or another form of dementia, but people who are just worried about it. People who have a family history, they have some cognitive complaints, and they think that they're just getting older and want to stay on top of it. So we have about 15% of people with Alzheimer's or dementia, 20% with mild cognitive impairment, which you could think of as sort of on a spectrum, and then 65% who are normal controls, or cognitively normal, where they might be having aging problems, but it's not necessarily memory problems associated with aging, but it's not necessarily distinguishable between normal aging and disease-based impairment. So this is great because we can compare people who do and don't progress to more impaired diagnoses, which is not typical in this research, where normally you would select on the dependent variable and just have people with Alzheimer's disease. So we interviewed these people once a year over time. We're working on a third wave of data collection now and just kind of get them as they come in. So we have these people, and I sit down in a room with them, and I have to measure their networks. To do that, we use something called name generators, a common way of collecting network data. For example, the Important Matters question from Marsden, like a famous data collection tool. Who are the people in your life with whom you discuss important matters? Who are the people you can really count on? Something to that effect. And from that, you get a list of individuals. So you can answer this to yourself in your head, and you'll probably come up with 3 or 4 people. And then based on that list of people they provide, we asked 20 or 30 follow-up questions about that relationship and that individual to try to populate these networks. In addition to this, though, we have 3 versions of this. And one problem with this item is that the idea of important matters is very vague, and people interpret that in a lot of different ways. So if you're going to conduct research using name generators, it's important to have some alternatives. For example, one thing that seems to help is defining your name generators towards some functionally specific goal. We ask them about their health. Who are the people that you discuss your health with, or who you can really count on when you have a physical, mental, or emotional problem? Okay? So we have several versions of that as well. Egocentric networks don't have the traditional sort of spaghetti plot structure of network analysis. Instead, you have a central individual, in this case an Alzheimer's patient. You have all of the people who they name in response to the name generator, maybe their spouse, children, other family members, friends, someone from the book club, Jenny from my grandma's apartment, all the people who make up those relationships. And then you can also ask about relationships between those individuals too. Now, importantly, when you collect this, the more people who you get, the difficulty of collecting the data exponentially increases, because every additional person is 20 questions, and then you have to ask about the relationships between all of those people. So it becomes more and more burdensome. So there are issues to think about in data collection if you do this. But you have networks like this, and in our case, we have 233 networks like that, all of them separate. You can think of this as nested data. So if this was students in schools, for example, as a classic multi-level case, here you have network members in patients. And you can analyze the data in the same way using multi-level models. As far as the makeup of these networks go, among those 230 people, there are about 1,100 network ties. The networks range from 1 to 17 individuals, and they average about 4.7 people who they talk to about important matters of their health. So already, this is revealing for research on caregivers and Alzheimer's disease, because it's not the case that there's just one key caregiver who people are relying on. Instead, it's more like 5 people. So in previous research, if we're only looking at that one relationship, we're overlooking most of their social context. And if we think that that might matter, we have to cast a wider net. And I didn't do the interview, which had 17 network members, but I pity that person, because that is a 2-hour interview. But most of the time, they were about 5. The networks were about 62% female, about an 8.5 out of 10 closeness, so still people who they consider to be relatively close to them. And then you can see the breakdown of relationship types. About 1/4 children, which are, again, probably 40 or 50 years old. About 1/4 friends, about 1/4 other family members, and only about 14% spouses. So that's what these networks look like. We have 230 of them and have to analyze them. Normally I talk more about culture, but it's not that important in this case. If we're interested in not just intimacy and closeness, but also knowledge, training, and experience, there's some questions that we asked in this research to try to get to that. One thing I'll talk about today is participants thought that 56% of their networks knew a lot about aging-related problems based on a simple scale, so knowing about memory loss, confusion, and other issues related to Alzheimer's disease. So I'll look at that item more. We also asked about trust in doctors, willingness to challenge a medical professional, and the education of network members. Okay, so now I'll talk about results. The first thing I'll talk about is network structure and how that changes with the progression of illness, so the architecture of relationships. The second thing I'll talk about is support provision, so sort of how resources flow within those structures. And then I'll talk about networks and health. So you have the structure, you have the flow of resources. Both of those things are distinct, and they're also different from consequences experienced by the participant. So first of all, looking at network structure, this is a heuristic based on testing descriptive statistic differences between people with normal cognition, mild cognitive impairment, and dementia. Here you have red nodes are kin, blue nodes are friends. The white node is the central ego and the relationships between them. So a few things stand out. First of all, people with normal cognition, older adults, just your average 70-year-old person who's having problems with memory and confusion, they have networks which are about 50% kin and non-kin on balance, a mix of close relationships with these bold outlines and less close relationships. They have people who are densely connected, like their family, but also some people who are loosely connected to the rest of the network. So you might have one of these weak ties here to someone you know from church or whatever it might be, just some one-off weak relationship. When people progress to mild cognitive impairment, those networks do look different. They get smaller, and these weak ties drop out. So people stop having sort of one-off relationships to this or that group, people who aren't associated with anyone else in their network. Once people have some diagnosable form of impairment, those are the first types of relationships that you no longer see in the networks. And then the pattern gets more exaggerated among people with Alzheimer's or dementia. In that case, those networks are very small, only about 3 or 4 people on average. They're extremely close, where everyone included is a 9 out of 10 on closeness. And everybody knows each other. It's just one dense unit around the ego. No other relationships are included in the networks anymore. So that's how the structure of these networks changed, and I think it's consistent with what we would expect, sort of a drawing in around a person who is becoming more and more impaired, who maybe has problems maintaining relationships outside of that dense core. Maybe some of the burden of managing relationships shifts from them to those other individuals, so you would see those less connected people dropping out. So then looking at support provision. So we have this structural change from normal cognition through people who have Alzheimer's. You can also look at how the resources flow. Here I'm using multi-level models, so network members nested in patients. And those models are good at looking at relationship level outcomes, like the provision of support. In this case, you have people who have mild cognitive impairment and people who have dementia, both of which are relative to someone with normal cognition. There are 6 different models here for different types of support: listening when upset, saying you care about, giving suggestions, helping with chores, lending money, and causing problems. So each of those 6 models made separately. And here you have, these are just the fixed effects from that regression, and a line for 0 with 95% confidence intervals. So for people with mild cognitive impairment, the takeaway is that all of these types of support overlap that 0 line. There is no difference in support provision for a person with mild impairment compared to someone with normal cognition. Now, if we think about this change, where the primary difference between normal cognition and MCI is the loss of these peripheral relationships, those probably aren't the most supportive people in our networks. So there really isn't a difference in support if you cut those people out, which seems to be the case here. The networks are functionally the same. However, when you get to people who have Alzheimer's or another form of dementia, there are some supportive differences. In this case, they're more likely to have any given network member who listens to them. They're more likely to have network members who give them advice and suggestions. They're more likely to have network members who help them with chores and sort of instrumental activities of daily living. All of which seems consistent with what we would expect. So not only do the networks become smaller and closer for people with dementia, they also are relatively more supportive network members being left behind, people who are taking care of their instrumental chores, providing them with emotional support, giving them advice. Okay. So this is using multi-level models to predict high-level outcomes. Another thing you can do is look at patient-level outcomes. And in this case, you have to aggregate your egocentric networks up to the patient level. So I moved to just those 233 cases, predicting quality of life for the patient based on aggregate network characteristics. So here's what you get when you do that. So this is just from linear regression from the example of patients. And I'm looking at average network knowledge of aging-related problems, average network closeness, and average frequency of contact. So what happens? Predicting quality of life. So first of all, as average network knowledge increases, for participants who have normal cognition, in blue here, there is no difference in their quality of life. It doesn't matter if they have the most or the least knowledgeable networks, their quality of life just stays flat, doesn't matter. However, for people with mild cognitive impairment in red or dementia in green, as average network knowledge increases, their quality of life increases as well. And actually, right around this 3/4 of the way up point, 2.75 out of 3, the significant difference between those with normal cognition and those with any form of impairment disappears. So as knowledge of aging-related problems in the networks goes up, the quality of life gap between normal controls and people with impairment becomes non-significant. So I think that this is very interesting, that knowledge is beneficial, but only for people who are impaired. I think that makes sense. But also that the effect sort of closes that gap would suggest that there is something to be said about reaching out to these broader networks and trying to increase knowledge among not just core caregivers, but also other people who participants might be interacting with. Now, in contrast, you can look at average network closeness. And in this case, more closeness helps everybody. As average network closeness increases, everyone's predicted quality of life goes up, including people with normal cognition. Everyone just likes having a more intimately close and supportive network. There's not a conditional benefit here. And then the last one, which I just include because, that's kind of weird, is frequency of contact. In this case, as frequency of contact, seeing people more often increases in the network, everyone's quality of life goes down. And it's sort of like, well, maybe there's some like hassling or bothering effect going on, but it might just be that frequency of contact is a signal of more problems. And if you're seeing people more often, you're dealing with more difficulties. So it's sort of this misleading signal, but interesting. Each of these is based on an interaction and controls for the other effects. Okay, so to wrap up, thinking about my research questions, if we return to the idea of who do older adults with Alzheimer's disease rely on for support, I think that this unique project looking at networks in Alzheimer's gives us some evidence to expand our attention from core caregivers to supporters more broadly. And to not assume that just because people are impaired that they have less social life or that other types of relationships are somehow less important for them than they are for everyone else. I think that more practically we can develop social needs assessments to see who is in a social context that has less knowledge or has less intimate support, and therefore who might be at risk of having a worse quality of life. And then second, when and why do networks matter for Alzheimer's disease? This study provides evidence that network structure and the provision of support do change as illness progresses, but the causal ordering is unclear. That's not something I've really talked about. We're collecting this data longitudinally to try to unpack more. Are networks changing in response to illness, or is illness changing as a result of pre-existing network structures? And you have to sort of tease that out, right? And then more about culture, which I didn't really talk about, but is important in my dissertation. So thank you. These are some grants. Yeah.
Thank you for a very interesting presentation. So to me, the most interesting stuff was the structural difference between normal people and the dementia patients. So the dementia patients has a very close and small mapping structure. So is that like the consequence of dementia or the cause of dementia? Because I think both scenarios are possible. So do you think which one is like the more plausible explanation, or have you looked at like any like before and after like difference?
Right. Yeah. So it's sort of that causal question where if someone is highly impaired and they have a very dense kin-centered network, did that network pre-exist their progression to a highly impaired state, like maybe because of a lack of social stimulation, a lack of activity where their cognition just worsens and worsens? Or is that network sort of reacting to impairment where people sort of circle the wagons to help people? So both causal directions. And at this point, I don't know. We've got 2 years of data for about 100 of the participants. So because they only come in once a year, it's hard to say. But we are looking at both directions. And fortunately, because we have all these normal controls, some are going to progress and some aren't. And we can compare people who become more impaired to those who don't in terms of their networks. So it's a question we're hoping to look at more. Yeah. Yeah.
With respect to the descriptive findings,
Mm-hmm.
it looks like your sample is pre-institutionalization, right? It's pre.
Yeah.
Is once you're really either hospitalized or in Alzheimer's wards, and the nurses, I would expect to become really key people. In fact, that haven't been family members in these situations.
Yeah. Right.
And it helps with relieving the sort of burden on the kin network. But I'd expect that super supportive nurses, basically people have their favorite nurses, and when the nurses go away, that's actually like a huge emotional sort of trauma. So it would be interesting to see what the network looks like. I expect it to still be very close and relatively few ties and all that, but after institutionalization.
Yeah. Right, yeah, so two things about that. So first, just the importance of medical professionals definitely increases. And where you have this one person who here, for simplicity's sake, I'm calling a friend, a lot of times that's a medical professional who's left over. And someone who they actually start to consider as friends because they see so often. But those people are the ones who stick around. And second, I would say this isn't the end of this continuum, where a lot of times the people who we can talk to, because these are all one-on-one interviews, are those who aren't completely impaired. And there were a few times where I sat down in the room with people and started the interview, which is a relatively burdensome process, like providing social network data, and had to stop because it was clear that they just didn't know anymore, they couldn't remember anymore. So we are censored at the right end, at the point where people are becoming very impaired, which is where I think these networks just kind of fall apart completely. So yeah, there's definitely more after that point though. Yeah. After that point though. Yeah.
So this is related to that point. As someone who has a parent that's going through this now, what you really notice is how people can't report these ties anymore.
Yeah.
And so I do wonder whether this, and the problem is that you may see changes that appear to
Right,
affect
yeah.
changes in network structure.
Yeah, this. Right, yeah.
So what would be really interesting would be to take one of the, say one of the child.
Yeah, we did that. Right, so the question is this real, regardless of the causal direction, or are these network changes the result of measurement? Where if you ask this person to remember their relationships and these weaker ties have dropped out, maybe they just forgot them, right? So that would be a huge catastrophic problem in this type of research. So we've tried to deal with this by also interviewing their informant. So everyone who comes to the clinic brings someone with them, usually that core caregiver. And we also interviewed those individuals about the participants' networks. So you get their perspective on who the participant talks to. And what you can do with those is compare the networks of people who, the informant, so those informant networks always differ a little bit, because my perspective on like my friends' relationships is probably like a little how it is. But you can compare people who are more or less impaired in terms of the difference between the informant network and the participant network. And so far, when we've looked at this, they differ to about the same amount. And I think that's because we do have that cutoff point where people are becoming so impaired that they really can't remember things like their relationships. We're no longer interviewing them. But also we have strategies built into the survey design where in subsequent waves, we remind people of who they mentioned in the previous year. But yeah, we're definitely sensitive to that and trying to make sure that we're not just getting design effects. Yeah.
I was curious if you felt that your research contributed to the literature or that institution in regards to the types of network members, whether age, gender, or kinship type, that were more likely to provide the participant with support.
Yeah. So that's the type of thing we're trying to unpack, like who is included in this network and who's providing what types of support. And I think there are contributions to be made there, with the caveat that we're only talking about older white people who are relatively well off. So we can speak to those supportive networks for these individuals, but more disadvantaged populations probably have different network dynamics, I would guess. And that's one limitation that we and the clinic itself are trying to improve by including more people who are different. Yeah. I don't know if that answers your question, but yeah.
Can you comment briefly on the cultural aspects of the measure?
Yeah, right. So a lot of my other research is about sort of health literacy or cultural health capital. The idea is that people can be more or less skilled at navigating the medical institution, like knowing what important is relevant to physicians, thinking about your health in an instrumental way, knowing how insurance works and how to manage treatments and pay for it, that type of thing. So my research and my dissertation focuses a lot on that sort of cultural competency for navigating medicine. And when I'm looking at knowledge in the networks, what I'm really interested in is how do participants who are less knowledgeable rely on people who know about healthcare to meet their needs. So that's the type of, I have a Journal of Health and Social Behavior paper about mental health patients and culture, which has more on that. Anyone else? Yeah.
I really have a question followed by a comment. So first, are you familiar with
Omar Lizardo?
Amar Don?
Oh, no.
So he's at Washington University in St. Louis,
Mm-hmm.
and his group has looked at social network change before and after a stroke.
Yeah,
So
right.
he was actually looking and found that it was in fact the changing. So you were commenting before on the causal arrow, and he did find that it was a response to the change in the patient's outcomes. So I think it would be really cool if you could compare your work.
Yeah, that's a
to
great
his
idea.
as you're like going through the publication process,
Mhm.
because it's a different medical issue, but the network response seems to be really, really
Right.
similar. So I think that could be really
Yeah, definitely.
If your email is on the final slide, I can send you some of it.
Yeah, I'll let you know. Yeah, especially since it's sort of like the same type of change, but slower and less chaotic probably than a stroke, which is
so
like,
they did it like over the course
Yeah.
of a year or 2 years.
Hmm.
It's a little fuzzy.
okay, great, thanks. Yeah, thank you everybody.
Thank you so much.
Yeah.